Welcome to Mobile Medical Media's review of emergency echocardiography, also known as limited ED echo. This module demonstrates how to obtain the 4 basic cardiac views and describes 3 abnormal states: pericardial effusion, cardiac standstill, and low ejection fraction. A 68-year-old woman with a history of emphysema and hypertension presents to the emergency department with acute shortness of breath. She is hypertensive, tachypnic, and hypoxic. Chest auscultation reveals bilateral wheezes. Bronchodilation therapy is initiated and a chest x-ray is ordered. You perform a limited ED echo to search for alternative causes of this patient's dyspnea. The limited ED echo utilizes 4 basic views: subxiphoid, peristernal long, peristernal short, and apical forechamber. The heart is assessed for pericardial effusion and cardiac contractility. A pericardial effusion appears as an anechoic stripe between the heart and pericardium. Limited ED echo is used to grossly assess cardiac function. This does not substitute for comprehensive echocardiographic estimation of ejection fraction. The limited ED echo is best performed with a convex, microconvex, or phased array probe. Some emergency medicine texts recommend pointing the directional indicator to the patient's right side during the cardiac exam. This maintains the same visual and anatomic orientation found in general diagnostic ultrasonography. In order to obtain the traditional echocardiographic views, the probe should be rotated 180 degrees with the directional indicator pointing to the patient's left side. The 4 basic views can be performed in any order. In the subxiphoid view, the probe should be placed in the subxiphoid space and aimed at the center of the chest in an almost coronal plane. Firm pressure may be required to obtain an adequate view. This may prove difficult in some patients. The liver is seen in the near field and provides an acoustic window through which the chambers of the heart can be visualized. Depth usually needs to be increased to adequately view the heart. The peristernal long view is obtained by placing the probe adjacent to the left sternal border with the indicator to the patient's right in a plane that runs parallel to the long axis of the heart from the right shoulder to the left hip. The right ventricle is seen in the near field, and the left ventricle is deeper and to the right on the screen. From this position, the peristernal short axis view is obtained by turning the probe counterclockwise so that the directional indicator is pointed at the right hip. This view produces a cross-sectional image of the cardiac chambers. The apical forechamber view is obtained by placing the probe at the point of maximum impulse approximating the apex of the heart, with the ultrasound beam pointing towards the inferior tip of the right scapula. All 4 chambers can be seen simultaneously with both ventricles in the near field. Small probe movements and adjustments are often necessary to obtain the best images. This peristernal view shows a moderate-sized pericardial effusion. In supine patients, effusions should be dependent and therefore collect in the posterior pericardial space. Hypoechoic signals seen anterior to the heart may be due to pericardial fat. Posterior pericardial effusions should be located between the descending aorta and the heart. Pleural effusions may be mistaken for pericardial effusions if the relationship between the effusion and the descending aorta is not recognized. Limited ED echo is helpful to search for cardiac activity in pulseless patients. Recent research suggests that in patients with no cardiac activity after 20 minutes of ACLS, mortality is 100%. This information may be useful in the decision to terminate resuscitative efforts. This clip shows the absence of any cardiac movement. Limited ED echo provides a qualitative assessment of cardiac contractility. It has been shown that emergency physicians can accurately recognize severely diminished ejection fractions. Here is a peristernal long axis view of a normal heart. Note the forceful ventricular contractions. Contrast that with this peristernal long axis view of a severely hypokinetic heart. Note the barely discernible movement of the ventricular walls. You perform a limited ED echo on your dyspneic patient and identify poor contractility. Chest X-ray demonstrates an enlarged cardiac silhouette and pulmonary edema. Treatment for decompensated heart failure is initiated. Recognize the limitations of ED echo. Valvular function, segmental wall motion abnormalities, and detailed description of cardiac function are beyond the scope of this application. The limited ED echo is not a substitute for comprehensive echocardiography. Be aware that anterior fat pads and pleural effusions may be mistaken for pericardial effusions. Sonographic assessment of cardiac activity may be helpful in the management of pulseless patients.